The title of this talk is Stroke. These are the class objectives. You do not need to read them. We will use them to chart our talk. This talk will be conducted in a question and answer format. The first question is, which of the following statements are true? A stroke occurred as an acute event. B, treatment for a stroke are time dependent. C, strokes often produce disabilities. D, all of the above. A stroke is an important subject, not only for the neurologist, not only for the internist, ER doctor, family physician, and surgeon, but for everyone working in the field of medicine. This is so because strokes occurred acutely, so they must be recognized by all first-line medical workers. Treatment is time-dependent and may include surgery, and strokes often produce disabilities requiring long-term psychological and physical rehabilitation. So the answer to this question is D. Next question. The term stroke has been used in the medical lexicon since A. 400 BC, B. mid-15th century, C. mid-18th century, D. mid-20th century. In this paper, titled The Definition of a Stroke, published in the Royal Society of Medicine Journal in 2017, this timeline was presented. 400 years before Christ, Hippocrates used the word apoplexy to describe a group of clinical manifestations resembling what we refer today as a stroke. The term apoplexy was still being used in mid-19th century, and it was not until mid-20th century that the term stroke replaced apoplexy in the common medical lexicon. So the answer to this question is D. Next question. All doctors and medical organizations agree on a definition of a stroke. A true, B false. The World Health Organization defines a stroke as rapidly developing clinical signs of a focal, at times global, disturbance of cerebral function, lasting more than 24 hours or leading to death, with no apparent cause other than of vascular origin. The American Heart Association published in 2013 a paper by the title of An Updated Definition of a Stroke for the 21st Century, which, as you can see, includes many authors. In the definition of a stroke put forward in this paper, unlike the one from the World Health Organization, stroke was not restricted to vascular accidents occurring in the cerebrum. It included the brain, meaning the cerebrum, cerebellum, and brainstem, the retina, and the spinal cord. In addition, they went on to define many terms, which I have listed in this frame, as you can see. We will address most of them during this talk. You do not need to read them at the moment. In addition to organizations, authors in different books have also used different definitions of a stroke and defined different terms related to a stroke. For the purpose of this talk, we are going to define 3 stroke-related terms. The first term is stroke. We will define a stroke as a clinical presentation lasting 24 hours or longer or leading to death within 24 hours due to acute disruption of blood flow to part of the brain, implying a focal lesion involving the brain, brainstem, and cerebellum, either because of occlusion, partial or complete, of a blood vessel, causing ischemia, or rupture of a blood vessel causing intracranial hemorrhage. Now that we have defined a stroke for this talk, we will define transient ischemic attack. And here, the distinguishing factor from a stroke is time. TIA is defined by the same features, except that the clinical presentation lasts less than 24 hours, usually 5 to 30 minutes. After defining transient ischemic events, we will define silent stroke. Silent stroke is defined as neuroimaging or neuropathological evidence of an all brain infarct or collection of chronic blood products within the brain parenchyma, supraarachnoid space, or ventricular system, not caused by trauma and without a history of acute neurological dysfunction attributable to the lesion. So the answer to this question is B. Next question. Which of the following is not a risk factor for a stroke? A. Female. B. African American. C. Obesity. D. Cigarette smoking. Risk factor for a stroke can be considered by dividing them in two groups, not treatable and treatable. Not treatable risks are old age, male, African American, and genetic factors. Treatable factors are smoking and high blood pressure, obesity, diabetes, hypercholesterolemia, which can be detected by finding in a patient thickened Achilles tendon, arcus cornealis, xanthelasmas, and tendinous xanthomas. Other treatable risk factors are heart disease, including atrial fibrillation, drug use, history of TIA, and finding consistent with a silent stroke. So the answer to this question is A. Next question. Which of the following types of a stroke is most frequent? A. Cardioembolic. B. Carotid or vertebral thrombotic stroke. C. Carotid or vertebral embolic stroke. D. Lacunar stroke. Strokes can be embolic, which produce occlusion. Arteries, as you know, become progressively narrower as they go distally. Any material, such as fat, platelet fibrin thrombus, or arteriosclerosis material of a relatively small size are able to travel proximally until the material gets stuck once the size of the artery narrows, and then it will produce the occlusion leading to ischemia in the territory irrigated by the artery. Embolic strokes often come from the heart, from the proximal aorta, from the common or internal carotid, from the vertebral artery, or from the basilar artery. Strokes can also be due to thrombus. Thrombus produce clinical manifestation due to hemodynamic changes. Thrombus may occur in the common or internal carotid, vertebral artery, basilar artery, large intracerebral arteries, and penetrating arteries. Infarcts involving the penetrating arteries are called lacunar. But if from all mechanism and location we have mentioned, we have to pick a single mechanism and location most frequently causing a stroke, we would have to choose cardioembolic strokes. So the answer to this question is A. Next question. Which of the following findings is least consistent with a cardiac or aortic embolic stroke? A. Present upon awakening from a night sleep. B. Abrupt onset. C. Presence of cardiac palpitations. D. Improvement of deficit shortly after first manifestation occurs. The clinical profile of an embolic stroke arising from the heart or the aortic arch is often quite distinct. They often occur during activity while the patient is exercising. Onset is abrupt. Palpitations are often present. Maximal deficit is usually at the onset and may improve as embolic material is pushed forward in the arterial tree. Cortical signs like aphasia, agnosia, apraxia, neglect, seizures, and incomplete hemisyndromes, meaning involving only one segment of the body, let's say the leg, and not the arms or vice versa, are common. So the answer to this question is A. Next question. Which of the following conditions do not predispose to paradoxical embolism? A. Patent foramen ovale. B. Pulmonary arteriovenous fistula. C. Hereditary hemorrhagic telangiectasia. D. Polycystic kidneys disease. Paradoxical embolism referred to embolism that occur as a consequence of an embolus originating in the venous system or traveling in the venous system prior to reaching the arterial system. Most paradoxical embolism arise from the pelvic or leg veins. Paradoxical embolism usually occurred in patients with abnormal communication in the heart, either in the atrial septal wall or in the ventricular septal wall. In addition to heart problems, lung abnormalities, as the one presented in this angiogram, consisting of a pulmonary arteriovenous malformation indicated by the black arrow, the feeding artery indicated by the white arrow, and the dilated draining vein indicated by the orange arrow, can lead to paradoxical embolism. Pulmonary arteriovenous malformation, as the one depicted here, may occur in patients with hereditary hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia can be detected by careful cutaneous examination. Signs, as you can see in these pictures, can be rather subtle because telangiectasia may be quite small. Paradoxical embolism occurs more common during straining in the bathroom, during delivery, weightlifting, and while performing a Valsalva maneuver. A Valsalva maneuver is a procedure often done during the evaluation of syncopal episodes. This procedure consists of cardiac and blood pressure monitoring while the patient holds his or her breath for 15 seconds, while attempting to blow air out of his or her nose. The steps in this procedure are meant to trigger cardiac and blood pressure reflexes mediated by the sympathetic and parasympathetic systems. So the answer to this question is D. Next question. Which of the following finding is least consistent with a carotid vertebral or large intracerebral vessel thrombotic stroke? A. Present upon awakening from night sleep. B. Stuttering course. C. Cortical manifestations. D. Occurring during Valsalva maneuver. Thrombotic events are due to hemodynamic changes. In this frame, you can see a normal artery, which consists of a smooth muscle, connective tissue, and endothelium. And here, an abnormal artery resulting from the collection of lipid, calcium, and cellular debris within the smooth cell muscle layer and disrupting the connective tissue. Large macrophages full of lipids, often referred to as foam cells, are very prominent in the thrombotic material. The clinical profile of thrombotic stroke may also have typical features that may help distinguish it based on clinical findings from other types of events. The deficit produced by thrombotic stroke is usually present upon awakening from night sleep. The course may be sudden, but it can also be stuttering or stepwise. There's usually no improvement once the deficit is established. Cortical signs similar to those described for embolic strokes are usually present. So the answer to this question is D. Next question. Which of the following CT images is consistent with a lacunar stroke? Please take a look at these 4 images and select A, B, C, or D. Hemorrhagic strokes are usually labeled according to the location of the blood. Hence, we talk about intraparenchymal hemorrhage, subarachnoid hemorrhage, and intraventricular hemorrhage. The labeling of ischemic stroke is less consistent across the literature. Extensive strokes are labeled cortical and subcortical infarcts. Stroke sparing deep structures are often labeled cortical infarcts, and those sparing the cortex are labeled subcortical infarcts. It is important to stress that ischemic and cortical strokes can progress to involve subcortical areas, and that purely ischemic strokes can become hemorrhagic, and that subarachnoid bleeding can produce vasospasm usually 3 to 10 days after the bleed and produce ischemic stroke. Vasospasm may be prevented by using calcium channel blockers. Another term used to label ischemic stroke is lacunar stroke, as we previously mentioned. 1/4 of all ischemic strokes are lacunar type. Lacunar strokes are small infarcts 2 to 20 millimeters in diameter that occur deep in the white matter, in the basoganglia and internal capsule, thalamus, and pons. Lacunar stroke can also involve the cerebellum. Lacunar strokes involve small penetrating arteries and are often associated with hypertension. This is a photomicrograph of a section of basoganglia showing 2 affected arteries. These arteries are displaying changes typical of hypertensive arteriopathy. Hypertensive arteriopathy consists of thickening and hyalinization of the arterial wall. Hypertensive arteriopathy is the cause of most lacunar strokes. In the next few frames, I will show you some pathological examples consistent with lacunar stroke. You can see in this section through the basoganglia a lesion consistent with a lacunar stroke. Lacunar strokes can also occur at the midbrain pontine junction, pontine region, and cerebellum. So the answer to this question is B. Next question. Which of the following findings is least consistent with a lacunar stroke? A. Pure hemisensory deficit. B. Clumsy hand syndrome. C. Ataxia hemiparesis. D. Pure motor hemiparesis affecting the leg more than the arm. Most authors cite 4 syndrome as being characteristic of lacunar stroke, while emphasizing that many other syndromes may occur as a result of lacunar strokes. The first syndrome I will call your attention to is called pure motor strokes hemiparesis. This syndrome is characterized by a dense hemiparesis affecting the face, the arm, and leg equally. The most frequent area involved is the posterior limb of the internal capsule, as indicated here. The second syndrome is ataxia hemiparesis. This syndrome consists of a combination of signs of cerebellar ataxia and pyramidal hemiparesis. Ataxia hemiparesis syndrome may occur with strokes in different areas, such as the posterior limb of the internal capsule, corona radiata, and pons. Most patients with this condition have more pronounced deficit in the lower extremity than in the upper extremity. The third syndrome is clumsy hand dysarthria syndrome. It is characterized by a hand that is more ataxic than weak. Dysarthria often associated with mild facial weakness. This syndrome is most often associated with a lesion at the basis pontis or genu of the internal capsule, contralateral to the affected arm. It is interesting that in a paper published in 1990, it was found that dysarthria, clumsy hand syndrome, predict pontine infarction, whereas another paper published in 2004 described the internal capsule as the most frequent site of involvement. The fourth syndrome we are going to mention is pure sensory stroke. This syndrome is characterized by hemifacial arm and leg numbness, all on the same side and the same intensity. The anatomical location most often involved is the ventral posterolateral nucleus of the thalamus, but pure sensory strokes can also occur with lesions at other sites, as represented in this frame. In this case, published in 2019, as you can see, indicated by the arrow, the site of the lesion corresponds to the medial lemniscal. So the answer to this question is D. Next question. A patient presenting in the ER with sudden onset of hemiparesis, confusion, and vomiting is likely to have A. a lacunar stroke, B. a hemorrhagic stroke, C. an ischemic stroke, D. a venous stroke. In this frame, you can see 3 examples of lacunar stroke. I will now show you examples of hemorrhagic strokes. As previously mentioned, hemorrhagic strokes are labeled based on the location of the bleed. Hemorrhagic strokes are often intraparenchymal, as you can see here, and here. In this case, in addition, the blood is also in the ventricles, so we call it intraventricular. Intraventricular hemorrhage can also occur in neonates, usually arising from the germinal matrix. They can also occur in the brainstem at different sites. Intraparenchymal strokes can be the consequence of intravenous malformations, but more often they are the consequence of rupture of Charcot-Bouchard microaneurysms. This type of aneurysms are more common in patients with hypertension. Another cause of intraparenchymal hemorrhage is venous infarction. Venous infarctions are rare. Hemorrhagic venous infarct are most commonly due to thrombosis of the dural sinuses. The sinuses most commonly affected are the superior sagittal sinus, the transverse and sigmoid sinuses, and the straight sinus. Hemorrhagic venous stroke are most often associated with hypercoagulation states. Another type of hemorrhagic stroke, as we pointed out in a prior question, is subarachnoid hemorrhage. Subarachnoid hemorrhage are often due to rupture of an aneurysm. Aneurysms can arise from any artery, the basilar artery, as can be seen in this specimen, from the posterior cerebral artery, but the most frequent site for aneurysm is the anterior communicating artery, anterior cerebral artery junction, as illustrated here. This CT shows a calcified aneurysm from the junction of the anterior communicating artery and the anterior cerebral artery. In this T2 transverse MRI, you can see the aneurysm as a signal void. Here you can see it in a sagittal T1 image, and here you can see the aneurysm in an MRA. Aneurysm can occur in any patient, but certain medical conditions predisposed to have them. Autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome predisposed to having cerebral aneurysms. The clinical profile of hemorrhagic stroke is variable. Hemorrhagic stroke may resemble embolic or thrombotic ischemic strokes, but patients with hemorrhagic stroke often have decreased level of consciousness, nausea and vomiting, hypertension, and signs of increased intracranial pressure. In patients with hemorrhagic stroke due to aneurysm, the onset of the symptom often occurs during exercise. So the answer to this question is B. Next question. The possibility of a suprarenal bleed can be ruled out based on a normal CT of the brain done within 6 hours of the acute event. A true, B false. What should you do if you think a patient has a suprarenal hemorrhage? An article published in 2019 addressed this issue, and it proposed the following steps in accordance with the guidelines put forward by the Headache Association. This algorithm used acute headache as the finding triggering the suspicion. The first step in a stable patient suspected of having a suprarenal bleed is to do a CT brain plane. If positive, as it is in this study, in which you can see blood hogging the brain in the peritentorial region, bilaterally, and in the cortical sulci. Such finding should prompt a neurosurgical consult and admission to the intensive care unit. If the CT is negative and you are seeing the patient more than 6 hours after the time of the ictus, you need to use your clinical judgment. If you feel that the risk of suprarenal bleed is low because the headache was not triggered by exertion and has resolved by the time the CT was interpreted, because the headache was not associated with syncope, vomiting, neck pain, or seizures, and because the neurological examination is normal, you may conclude that no bleeding has occurred. This option should not be chosen unless the patient can be closely followed. On the other hand, if clinical suspicion is high, if you are uncertain or the patient cannot be followed, you should consider other diagnostic possibilities. Now, let's hold for a second as to what diagnostic possibilities you should consider and go back to this negative CT. We go back in order to talk about what to do if the patient is being seen within the first 6 hours of the ictus. In this case, the need for further diagnostic testing is absolute, because in the first 6 hours after suprarenal bleed, the patient may not show any neurological deficit nor physical signs of increased intracranial pressure or meningismus, nor, for that matter, blood in the CT. Hence, the lack of red flag findings and a normal CT plane during this period does not exclude a suprarenal bleed, and further testing is necessary. So we must decide about which diagnostic modality to use next. The choices are LP, CT, angiography, or MRI of the brain. This decision is made based on several factors: on the anticoagulation status of the patient willingness to undergo spinal tap, history of surgeries in the spinal region, or any contraindications for a lumbar puncture, and, as stated above, the time from the ictus. So we decide to do a spinal tap. If the spinal tap is negative, we can conclude no suprarenal bleeding has occurred. If the spinal tap is positive for suprarenal bleed based on the presence of xanthochromia visually detected or by spectroscopy, or actual blood in the CSF present in the same amount in the first collected tube and the last collected tube, or if there is microscopic evidence of blood, the diagnosis of subarachnoid bleed is established, and the patient should be admitted to ICU and a neurosurgical consultation requested. Another possible test modality to consider, based on the factors we previously mentioned, is to do, as we previously mentioned, a CT angiogram. If positive, as in this image where we find indicated by the arrow an aneurysm, we have to conclude that an aneurysm is present, thus increasing the chances of the patient having had a subarachnoid bleed. So, a positive CT angio warrants a spinal tap, as long as it is considered safe. Again, if the spinal tap is negative, you can conclude that the patient has an aneurysm but has not bled. If the spinal tap is positive, you can conclude that the patient has an aneurysm and has bled and take the appropriate steps that we have considered before. On the other hand, if the computer angiogram is negative, you can conclude that the patient does not have an aneurysm larger than 4 millimeters and probably has not bled. The third diagnostic modality we can use is MRI. MRI becomes very reliable after 24 hours, but even before, its ability to detect blood after 6 to 12 hours is rather good. If the MRI is negative, you can conclude, coupled with the negative CT done initially, the exam and the clinical finding that there is no subarachnoid bleed. This is an almost 100% certainty if the MRI was done 24 hours after the ictus. If the MRI is positive, as shown here where you can see blood in the cortical sulci, you can conclude that a subarachnoid bleed has occurred and take the appropriate steps that we have already mentioned. So the answer to this question is B. Next question. Which of the following clinical finding is useful to distinguish internal carotid artery system stroke from vertebrobasilar artery system stroke? A. Visual field cut. B. Dysarthria. C. Hemiparesis. D. Diplopia. The first step in the evaluation of a patient with a stroke is to distinguish between internal carotid system and vertebrobasilar artery system involvement. The main arteries in the internal carotid artery system are the ophthalmic artery, the first clinically significant branch of the intracranial internal carotid artery, the anterior cerebral artery, and the middle cerebral artery. Involvement of these arteries will produce monoocular blindness if the ophthalmic artery is involved, contralateral leg weakness, aphasia, hemiparesis with ipsilateral lower facial weakness, hemiparesis with contralateral gaze preference, hemisensory loss involving the body and face ipsilaterally, dysarthria, and visual field cuts. The vertebral basilar artery system includes the vertebral arteries, the basilar artery, the cerebellar arteries, and the posterior cerebral artery. Clinical manifestations of vertebrovascular involvement include dysarthria due to cerebellar involvement, visual field cut, cross hemiparesis, cross sensory loss, vertigo, drop attacks, diplopia, and tinnitus. So the answer to this question is D. Next question. Cerebral blood flow is constant at different ages and the same in all brain regions. A true, B false. In this frame, I have represented the cerebrum size in relation to the percentage of total body for different parameters. The cerebrum is a needy organ. It is estimated to be about 2% of the body weight, uses 15% of cardiac output, consumes 20% of oxygen the body consumes, and accounts for 25% of the total sugar consumption of the whole body. Hence, it is an organ with high metabolic demands. Cerebral blood flow values given as normal by different authors vary, but they all agree that cerebral blood flow adjusts to the metabolic needs for oxygen and glucose at different ages and at different brain regions. Cerebral blood flow values differ according to age, as we previously mentioned. During infancy, cerebral blood flow is about 20 to 40 ml per 100 gram per minute. During childhood, 65 to 100. During adult, 35 to 60. In addition, cerebral blood flow of different regions differ. In adults, the flow in the perisylvian temporal region is about 70. In the frontal region, 55. In the thalamus, 75. And in the white matter, 35. It cannot be overemphasized that the values given here are not universally agreed and that the reality is that they change moment to moment based on regional activity. In this frame, I have represented cerebral blood flow values. The green rectangle represents normal cerebral blood flow, which for the purpose of this talk we will define to be 35 to 60 millimeters per 100 gram of tissue per minute, 50 milliliters per 100 grams of tissue per minute being the value I have come across more often as the normal value. A fact almost universally agreed at this moment is that cerebral blood flow of 20 ml per 100 grams per minute or below is bad for the brain. So the answer to this question is B. Next question. Sustained intracranial pressure values of greater than 40 millimeters of mercury indicate severe, life-threatening intracranial hypertension. A true, B false. In this frame, I have introduced a table with normal values for intracranial pressure depending on age. Adult intracranial pressure varies from 5 to 15 millimeters of mercury. The same goes for older children. Young children normal intracranial pressure is 3 to 7. At term, the normal intracranial pressure is 1.5 to 6. This chart makes it possible for us to display the relation between intracranial pressure and cerebral blood flow. In this frame, you can see displayed the relation between intracranial pressure and cerebral blood flow pressure as a brown line. I have now represented normal intracranial pressure by the interrupted purple lines between 5 and 15 millimeters of mercury. The assumption, based on philosophical considerations, has been made that normal intracranial pressure correlates with normal cerebral blood flow. Standing on this assumption and clinical information that backs it up, we can further say that between intracranial pressure of 15 to 40, the brain is at risk, and beyond 40 millimeters of mercury, intracranial pressure produces critical drop of cerebral blood flow. So the answer to this question is true. Next question. In the presence of normal brain autoregulation, cerebral blood flow remains relatively constant when the cerebral perfusion pressure is dash millimeters of mercury. A. 25 to 75, B. 50 to 140, C. 150 to 200, D. 100 to 180. Cerebral perfusion pressure results from two conflicting forces. One force is the mean arterial pressure. The other one is cerebral venous resistance. The mean arterial pressure pushes intracranial blood, and cerebral venous resistance resists the push. The cerebral venous resistance is equal to either the intracranial pressure or the central venous pressure, whichever one is higher. In most situations, intracranial pressure is higher than cerebral venous pressure. So we can say that in most instances, cerebral perfusion pressure can be calculated by subtracting from the mean arterial pressure the intracranial pressure. I hope you are familiar with this chart by now. It is the same graph we have just used to answer the last question. I have now introduced cerebral perfusion pressure in the x-axis. In a brain with normal autoregulation, cerebral blood flow is maintained within normal limits when the cerebral perfusion pressure is between 50 and 140 millimeters of mercury. Cerebral perfusion pressure above 140 can produce vascular rupture and bleeding. Cerebral perfusion pressure below 50 places the brain at risk of infarction. It is important to stress that the normal values for cerebral perfusion pressure are defined by the cerebral perfusion pressure parameters that maintain normal cerebral blood flow. So the answer to this question is B. Next question. In the presence of normal brain autoregulation, cerebral blood flow remains relatively constant when mean arterial blood pressure is dash millimeters of mercury. A. 25 to 75, B. 50 to 150, C. 75 to 100, D. 100 to 200. The mean arterial blood pressure can be estimated by subtracting from the systolic blood pressure the diastolic blood pressure and dividing the result by 3. Then adding the result of this division to the diastolic blood pressure. This graph brings together cerebral blood flow and mean arterial blood pressure. In the presence of normal autoregulation, the relation between mean arterial blood pressure and cerebral blood flow can be represented by this curve. Normal mean arterial pressure, which unlike cerebral perfusion pressure is judged independent of cerebral blood flow, correlates with normal cerebral blood flow. Even a wide range of pathological mean arterial pressure on both sides of normal mean arterial pressure range do not pathologically affect cerebral blood flow perfusion. As you can see in this graph, cerebral blood flow is kept within normal limits with mean arterial pressure ranging from 50 to 150 millimeters of mercury. This being the case with normal brain autoregulation. But in cases of abnormal or no cerebral autoregulation, as may occur in hypoxic ischemic encephalopathy or following head trauma, only when mean arterial blood pressure is kept in the normal range from 70 to 100 millimeters of mercury will cerebral blood flow be kept in the normal range. So the answer to this question is B. Next question. Which of the following areas is less vulnerable to stroke in a patient with severe acute systemic hypotension? A. Broca's area, B. Somatosensory area, C. Superior parietal lobule, D. Cerebellar hemispheres. This graph was previously presented to illustrate the relation between mean arterial blood pressure and cerebral blood flow in patients with normal autoregulation. I will use it now to talk about arterial hypotension. When the mean arterial pressure falls below 50 millimeters of mercury, cerebral blood flow drops significantly. The drop in cerebral blood flow will not affect all areas of the brain equally. The areas irrigated by the terminal branches of major arteries, referring to as watershed areas, will be more affected. In this figure, the anterior circulation is drawn in pink and the posterior circulation in blue. The area inside the ovals indicate the watershed areas. The watershed area corresponds to the border zone between the anterior and middle cerebral arteries, most notably in the superior posterior frontal and superior anterior parietal regions. These regions are involved in motor activity and somatosensory perception. The area irrigated by the terminal branches of the middle cerebral and posterior cerebral arteries, this area is involved in the irrigation of visual structures. The terminal branches of the posterior inferior cerebellar artery and the superior cerebellar artery, and less frequently the terminal branches of the middle cerebral and anterior cerebral arteries in the frontal region. Involvement of this area produces transcortical motor aphasia. So the answer to this question is A. Next question. Under physiologic conditions, cerebral blood flow is more sensitive to changes in PCO2 than PO2. A true, B false. PCO2 is a strong influence on cerebral blood flow. This graph looks at cerebral blood flow and PCO2. The curve introduced reflects the relation between cerebral blood flow and partial CO2. Normal PCO2 values are from 35 to 45 millimeters of mercury. Cerebral blood flow is normal between these ranges. But equally important is that PCO2 from at least 5 to about 90 millimeters of mercury has a linear relation with cerebral blood flow, and that PCO2 values from 35 to 25 millimeters of mercury decrease cerebral blood flow, but do so while maintaining cerebral blood flow within the normal range. Now let's look at oxygen. Normal oxygenation levels ranges from 95 to 100 millimeters of mercury. Cerebral blood flow is safely maintained during this level of oxygenation. This level of cerebral blood flow is maintained even with oxygen levels of 50 millimeters of mercury. It is only after reaching 50 millimeters of mercury that a drop in oxygenation starts affecting cerebral perfusion. The response to these levels of oxygen, that is to levels of oxygen below 50 millimeters of mercury, is an increase in cerebral blood flow. So the answer to this question is A. Next question. Which of the following structure is least sensitive to lack of oxygen? A. CA1 region of the hippocampal formation. B. Purkinje cells of the cerebellum. C. Globus pallidus. D. Layer 1 and 2 of the cerebral cortex. In the hippocampal formation, the CA1 region is most vulnerable to hypoxia. In the cerebral cortex, layers 3 and layer 5 are most sensitive to hypoxia. Of the basal ganglia structure, the globus pallidus is most sensitive to hypoxia. And in the cerebellum, Purkinje cells are the most sensitive to hypoxia. So the answer to this question is D. Next question. When cerebral blood flow falls below 20 ml per 100 gram per minute, oxygen extraction starts to fall and changes may be detected on A. CT of the brain, B. Skull X-ray, C EEG, D brain angiogram. EEG is a practical tool to detect drop in cerebral blood flow. Cerebral blood flow manifests by slowing. As you can see here, the slowing is first intermittent, later continuous. So the answer to this question is C. Next question. Cerebral blood flow in the ischemic penumbra is about dash millimeters per 100 gram per minute. A 50 to 55, B less than 12, C 12 to 22, D 23 to 35. An infarct has different pathological areas. The infarct core denotes the part of an acute ischemic stroke which has already infarcted or is irrevocably destined to infarct regardless of reperfusion. It is also referred to as established infarct zone. The ischemic penumbra denotes the part of an acute ischemic stroke that is at risk of progressing to infarction, but still salvageable if reperfused. The penumbra is surrounded by an area of oligemia. The area surrounding the penumbra is considered not at immediate risk for infarction. There is a correlation between the different pathological areas and cerebral blood flow. At the core of the infarct, cerebral perfusion is very compromised, usually less than 12 ml per 100 gram per minute. In the penumbra, cerebral blood flow is about 12 to 22 millimeters per 100 gram of tissue per minute. Blood flow around the penumbra is about 23 to 34. Surrounding this area is normal brain. So the answer to this question is C. Next question. Treatment with TPA and or thrombectomy is indicated within 3 to 4.5 hours after stroke in patients with no risk factors for bleeding once blood pressure is controlled and CT brain plane shows no blood. A true, B false. In this frame, you can see the evolution of a stroke. The orange area is infarcted, implying that the tissue is already dead or irreversibly damaged. The light green area is the penumbra. 10 minutes after stroke, the infarcted area is relatively small compared to the penumbra. By 6 hours, all the penumbra will become an infarct. Hence, treatment within 3 and 4.5 hours of a stroke onset using IV injection of recombinant tissue plasminogen activator and or thrombectomy may change the natural progression of a stroke and decrease the extent of the infarcted area. So the answer to this question is true. Thank you very much for your attention.